Dr. Willem Einthoven is a Dutch physician and physiologist who invented the first practical ECG machine. He won the Nobel Prize in 1924 for this device. Initially, Dr. Einthoven used a string galvanometer in order to record the very tiny electrical potentials that travel across the surface of the heart. In this image, you see both a picture of Dr. Einthoven and his first practical ECG machine. Unfortunately, this machine weighed approximately 600 pounds and required at least 5 people to operate. In order to understand how a 12-lead ECG is recorded, we must first discuss how a single lead is created. In this example, the negative end of the lead is connected to the right arm, and the positive end is connected to the left arm. Every lead has a positive and negative end. Electricity must flow from one of these to the other in order to create a recording. The height or amplitude of the signal that is recorded onto the graph paper is dependent on 2 different things. The first is the amount of myocardial tissue which is being depolarized. The greater the mass of tissue, the larger the voltage that it generates. The ventricles, therefore, generate a far larger signal than the atria because they are larger. The second issue, which contributes to the height or amplitude of the signal recorded, is the direction of the vector of depolarization relative to the direction of recording on the lead. In this example, if a vector of depolarization is traveling parallel to the orientation of the lead from the negative pole to the positive pole, then a large and positive signal will be recorded on the graph paper. The signal is positive because the vector is moving from the negative end towards the positive end. If the direction of the vector is reversed and the signal moves from the positive end to the negative end, then an identical signal will be recorded, but it will be in the negative direction. If the exact same amount of mass is depolarized, as seen in this last vector of depolarization, but the angle of depolarization is somewhat off parallel to the direction of the lead involved, then the amplitude of the signal will be smaller. As seen in this final vector, you can see that it is off-axis relative to the direction of the lead in question. Because it is off-axis, a smaller signal is ultimately recorded. It's still moving towards the positive end, therefore the recording is still deflected in the upward direction away from the baseline. If the vector were moving entirely perpendicular to this lead, then no signal would be recorded at all. Now that you understand the concept of a bipole, we can examine the first 3 standard leads of a 12-lead ECG. These 3 leads were originally designed by Einthoven himself. One electrode is placed on the right arm, the next on the left arm, the next on the left leg, and the final lead, which is a grounding lead, is placed on the right leg. Lead 1 spans between the right arm and the left arm, with the left arm being the positive end. Lead 2 spans between the right arm and the left leg, with the leg being the positive end. And lead 3 spans between the left arm and the left leg, with again the leg being the positive end. These 3 leads comprise what is called Einthoven's triangle and represent the first 3 leads of a standardized 12-lead ECG. The next 3 leads of a standardized 12-lead ECG are called the augmented leads. All leads require a positive and a negative end. However, for the augmented leads, the negative end is an imaginary centralized point. If we take the electrodes on the right arm, left leg, and right leg, and centralize them into one common point, that point ends up being in the center of the body. This point serves as the negative end of the 3 augmented leads. Lead AVR spans between that centralized imaginary point and the right arm, with the positive end being at the right arm. Lead AVL spans between that centralized imaginary point and the left arm, and AVF between that center point and the left leg. These comprise the next 3 leads of a standardized 12-lead ECG. The first 6 leads of the standardized 12-lead ECG are called the limb leads. They transect the body in a frontal or coronal plane. The next 6 leads are called the precordial leads, and they transect the body in a horizontal, transverse, or axial plane. To properly place the precordial leads on the chest, we must first be familiar with the intercostal spaces. The space between the first and second rib is called the first intercostal space. The second space is between the second and third, and so forth, counting down the first 5 intercostal spaces. Lead V1 is placed in the 4th intercostal space, just to the right of the sternum. Lead V2 is placed in the 4th intercostal space, just to the left of the sternum. Lead V4 is placed in the mid-clavicular line in the 5th intercostal space. Lead V3 is placed halfway between leads V2 and V4. Lead V6 is also in the 5th intercostal space, but it is placed all the way around in the mid-axillary line on the left side. Lead V5 is halfway between leads V4 and lead V6. These are called the precordial leads and comprise the next 6 leads of a standardized 12-lead ECG. The final thing which must be understood before interpreting a 12-lead ECG is the standardized graph paper on which every 12-lead is printed. Time is moving across the horizontal axis. Amplitude, which is measured in volts, is moving in the vertical axis. At the leftmost side of every 12-lead ECG is a standardization box. This standardized signal is always 1 millivolt tall and 200 milliseconds wide. If the 12-lead ECG has been recorded using the standard recording principles established years ago, then this standardization signal should be 2 large boxes tall and 1 large box wide. In other words, the gain is set to normal and the speed of the recording paper is set to 25 millimeters per second. If this standardization signal is 2 large boxes wide, then the paper has been set to run at twice the normal speed, and all your measurements of duration and time must be adjusted. If the standardization signal is 4 large boxes tall, then the gain has been turned up by a factor of 2. It is therefore very important to establish that the standardization signal is 2 large boxes tall and 1 large box wide. As long as this standardized signal is recorded in that way, then the following measurements of time are true. 1 small box equals 0.04 seconds in time, or 40 milliseconds. 2 small boxes is 80, 3 120, 4 160, and 5 small, or 1 large box wide, equals 0.2 seconds in time, or 200 milliseconds. Now let's put everything that we've learned so far together. Here is our first 12-lead ECG to look at. You can see that the 12 leads are organized in 4 groups of 3. Leads 1, 2, and 3 represent Einthoven's triangle. Leads AVR, AVL, and AVF are the second group of 3. Each of these leads has its positive end at the tip of the right arm, the left arm, and the foot respectively, with the negative end being at the imaginary center point of Einthoven's triangle. These 6 leads all transect the body in the frontal plane. Leads V1 through V6 comprise the next 2 sets of leads and finish out the 12-lead ECG. Each of these leads has its positive end at the tip of the electrode and the negative end at the imaginary center point of Einthoven's triangle. These leads transect the body in the horizontal plane. Look at the beginning of each of these tracings. You can see that the standardized signal is present at the beginning of every one of these tracings. In this case, the signal is 2 large boxes tall and 1 large box wide. This signal is the normal height and width for a standardization signal. We now know that 10 millimeters up represents 1 millivolt in amplitude, and we know that the standardized box is always 200 milliseconds wide. In this case, 200 milliseconds corresponds to 5 millimeters, so the paper speed is running at the normal speed of 25 millimeters per second. This standardization signal is completely normal, We can therefore assume that all of our expected measurements for amplitude in millivolts and for time in seconds will be normal. The final thing which is notable on this 12-lead ECG are the 3 continuous tracings at the bottom of this strip. These 3 leads were determined by a setting on the ECG machine at the time of the recording and represent what is called a rhythm strip. They allow the reader to look at the same lead across the entire duration of the recording to detect nuances in the rhythm itself. These are additional to the 12-lead ECG, which is present in the tracing above. An ECG recording represents the summation of all the cells in the heart as they depolarize. The larger the number of cells, the greater the electricity transmitted. In order to understand what the heart does as a whole, we first need to look at one cell as it depolarizes. This graph shows a cardiac action potential, which is typical for almost every cell in the heart. This action potential curve represents a sodium-dependent cell. Notice that the resting membrane potential is extremely negative and is at approximately negative 96 millivolts. This means that in the resting state, the cell is always ready for depolarization. The rapid upstroke at the beginning of the action potential curve represents the rapid influx of sodium into the cell. The remaining portions of this action potential curve are dependent on ions such as potassium, chloride, and calcium. Once the action potential is over, the cell repolarizes and returns to its negative resting membrane potential. This cascade is then repeated in rapid fashion across all the cells in the heart. It is the summation of each of these cells as they depolarize that represents the electrical signal that becomes the 12-lead ECG. This graph also represents a cardiac action potential. However, this is from a pacemaker cell. The sinus node and the AV node and any other automatic tissues within the heart generally exhibit this type of behavior. The first action potential graph was of a sodium-dependent cell. Pacemaker cells are calcium-dependent. You will notice that the resting membrane potential rises slowly rather than being fixed, as in the sodium-dependent cell. And once a critical point is reached, then automatic depolarization happens. That is what gives this particular type of cell automaticity, or the ability to depolarize itself. The rapid upstroke at the beginning of this type of cell is dependent on calcium rather than sodium, and is somewhat slower than the sodium-dependent cell. The remaining phases of this action potential curve are also dependent on potassium and sodium. However, the chief driver for depolarization here is calcium rather than sodium. The differences between an automatic pacemaker cell that is calcium-dependent and a regular cardiac muscle cell, which is sodium-dependent, cannot be seen on the 12-lead ECG. These differences simply dictate their differences in behavior, as well as their responsiveness to various antiarrhythmic medications. The following drawing represents a schematic of the heart's electrical system. The beginning of most impulses in the heart is the sinoatrial node. This represents the normal pacemaker for the heart, as it usually sets the heart rate. The sinus node, or the sinoatrial node, is located at the uppermost and rightmost portion of the right atrium. Therefore, signals which begin in this area must travel from the right of the heart to the left and from the top of the heart down. These signals spread through both the right and the left atria. When they reach the atrioventricular node, this area serves as a junction box, communicating signals from the atria to the ventricles. The signals enter the AV node and then travel to the bundle of His. The bundle of His represents the beginning of the His-Purkinje system. The His-Purkinje system is the network of electrical fibers that transmit information through both the left and the right ventricles. The bundle of His bifurcates into the left bundle and the right bundle. The left bundle further bifurcates into the left anterior fascicle and the left posterior fascicle. The right bundle has no such bifurcation. This wiring system allows electricity to spread rapidly through all portions of the chamber in question, thereby providing a more synchronous integration of electrical conduction and contractility. Now let's turn our attention to the actual recordings. Every ECG complex is made up of several waves. Einthoven originally designated these waves the P wave, the QRS, and the T wave. These designations have remained even after 100 years of use. The P wave, which is the first element traced on an ECG recording, is the depolarization of the atrial tissue. You will note that the origin of the sinus node complex does not appear in this tracing. The discharge of the signal from the sinus node cannot be seen. All that we can see is the effect of the sinus node firing on the atrial tissue. The atrium contracts as a uniform body, causing this P wave. The QRS is the depolarization of the ventricles. The Q wave is the first downward deflection of this signal. The R wave is the first upward deflection of this signal. And the S wave, which represents the first downward deflection after the R wave. It is possible for a QRS to have only an R and an S wave, or only a Q and an R wave, or to have an R wave, an S wave, and then a second R wave, designated R prime. In all circumstances, it is called a QRS signal and represents the depolarization of the ventricles. The T wave, which is the final traditional recording on the ECG signal, represents repolarization of the ventricles, or the resetting of the electrical signal. Make sure to correlate the P, QRS, and T waves to the action potential curves that we just learned about. The P wave corresponds to phases 0, 1, and 2 of the standard action potential curve. Repolarization of the atria does occur, but cannot be seen on the ECG tracing because the atrial tissue is too small and additionally is covered up in time by the presence of the QRS, which is a much larger signal. The QRS wave represents depolarization of the ventricles and is therefore phases 0, 1, and 2 of the action potential curve. The T wave, which is repolarization of the ventricles, is represented as phase 3 on the action potential curve. Now that we know the correct terms for each of the tracings on a standard cardiac cycle, we have to define each of the intervals and spaces between these waves. The PR interval is from the beginning of the P wave to the first recorded signal of the QRS complex. Intervals and segments are two different things. The PR segment is the space between the end of the P wave and the beginning of the QRS signal. The QRS complex is from the beginning of the QRS, in this case the Q wave, to the end of the S wave, but it is from the beginning to the end of the QRS signal. The ST segment is from the end of the QRS to the beginning of the T wave, and the QT interval is from the beginning of the Q wave to the end of the T wave. You will notice segments are always exclusive of the waves, and intervals include one or both of the waves at the beginning or the end of the interval in question. These are the standard signals on every ECG complex.